This conference will now be recorded.
Okay, Terry, go ahead.
Good afternoon, everyone. I don't know if there's anybody coming from the West Coast. I don't know that they are, which would still be, I guess, 11 o'clock out there. But welcome to our Cohort D discussion of the day. And again, I just want to give a little bit of background in essence, because we are unable to have an in-person meeting this year due to some restrictions, et cetera. We are going to be using webinars and then cohort discussions so that we can both get some of the information out and also have an opportunity for our flex coordinators and state office folks, et cetera, to kind of talk amongst themselves. So kind of the biggest secret here is that we want to make this dialogue as rich as we possibly can. So it's a technique that we've used often with hospitals, as a matter of fact, one that I think we recommend, although, kind of the nature of the conversation depends a great deal upon kind of who's on and how willing they are to talk and share. But those of you that I think most of you know each other, and so I'm hoping that you'll feel free to kind of jump in and talk. I may very well just ask a question of you if I know of a program, or just wonder why you made a particular comment in terms of the homework exercise, et cetera. But again, let's, we get out of this discussion pretty much we put into it, so I really appreciate you guys participating fully. And if you're not using it with your hospitals, to me it's another means of getting leaders to talk together. And we've done a good bit of it in the Mississippi Delta, in the region that we've been working in down there. And sometimes it goes really great. Sometimes it's a little more difficult. But this is the first session. And the homework basically was not intended to be too heavy lifting. Hopefully you didn't struggle with it. What we were really trying to get you to do is to think about kind of some of the issues. In this particular hospital is actually a hospital that is fairly real. All the names that are on there have been changed in that regard, but a hospital that I worked with years ago. And some people have remarked, gosh, this hospital is such a mess, they could hardly believe that it was real. But all of the circumstances that were present in this hospital basically were real ones in a hospital that we worked with years ago. And the good news on that, I can tell you, is that with some assistance from some really excellent resource people, I won't even mention the consultants used on it. This hospital was able to survive and has come out as a really pretty high performer in the state that it's in. It took a lot of support and a lot of help as such, and so we thought we kind of use it as a real life example. But the conversation today, I really want to center more around basically what's happening in your state, and have you share a little bit, particularly in the area of leadership and strategic planning. So with that, I'm going to show you the learning objectives today is just to think about, from a framework standpoint, kind of how you apply leadership and strategic planning as critical success factors to this case study or to hospitals in your state. We'd like to hear from you what's been going on in your state, and as I said, if let's get as much discussion as possible. I may just ask you, what's going on in Tennessee, for example, or et cetera, in this area. What are you observing? And this way, we're gaining a lot of information, and I think conversely, you're sharing it with each other as well. And finally, in the context, let's talk a bit about, given a hospital with multiple needs, and I'm going to bet that there's quite a few hospitals out there in the country that have needs almost this acute. Kind of where do you start as a flex program or as a group of consultants coming in, et cetera? And so we'll want to keep some of those ideas in mind as well as we're in the discussion. And so I think that pretty much says pretty much the same thing. We're using a Moodle application here, and again, it's something that I think is providing some really good support for us here at the center. Now, one of the things I wanted to start out with is I don't know how many of you seen it. You know, in the presentation that we did, I think it's now been a little over a week ago, we talked about using a framework. And one of the frameworks that really makes sense to us is a Baldrige framework. It comes out of the Department of Commerce. It has been shown to have extraordinary value for organizations, not just healthcare organizations, but organizations in general. And whether you use a Baldrige framework or you know, as a model, you could use it for your flex program, hospitals can use it, et cetera, or whether you choose, you want to choose another type of framework. You know, Studer, for example, the Studer group some of you are familiar with, have a really nice framework as well. Or if you just want to devise a framework that is going to give you a kind of a multi-concept, systematic approach, it's really pretty much entirely up to you and to the hospitals that you work with. But we are recommending that you think through the possibilities of either suggesting or supporting the use of frameworks in general with your hospitals. Now, some fuel to that concept basically just came out of the President's Council on Science and Technology. So this is a group that is put together to advise the administration. And in May 29th, they just issued a report to President Obama. Basically what they're saying is in the area of healthcare, because this whole thing is focusing on healthcare, is that we really need to take more of a systems approach in our United States hospitals. And in that regard, they've made a very specific recommendations. One of, I think, 4 or 5 that they've made is that healthcare organizations use Baldrige and the Baldrige framework. I'm not sure how that's going to get played out. I know talking to Christy Martinson, there's no plans to dictate anything of this nature, so don't feel that it's prescriptive in that regard. But in essence, what the President's Council is saying is that we should be using systems frameworks in healthcare, and they're pretty strongly recommending that healthcare organizations choose Baldrige. Again, kind of a coincidence that it happened, but in essence, we're kind of moving forward kind of with this framework with kind of that concept in mind. One of the other things I can tell you is that we have kind of ongoing conversations with the national Baldrige organizations, including the state that probably serves each of the state organization, the Baldrige organization serving your state, and they have indicated a pretty significant interest in putting resources together, putting state designation and awards together, and putting state resources that would be available to both you and the critical access hospitals. Again, it's not being prescribed, or it's not going to be absolutely a requirement, but again, the more resources we have out there, the better we're going to be. And I know of at least one state, which is Nebraska, who have used Baldrige as a framework for their flex programs, and at least some states across the country who have used Baldrige as well. So it's just a way of looking at the world and making sure we're hitting the key points. Within the Baldrige framework is the area of leadership that starts there, and in the Baldrige concepts, leadership is the far and away the most important of these components. And in fact, when they weigh the scores on the Baldrige award itself, leadership counts double any of the other ones that are on there. So it's why my experience has been in so many cases, it's generally always about the leadership. When you have extraordinary leadership of hospitals, networks, it applies pretty much across the board. You tend to have good quality. You tend to have a happy workforce. You tend to have patients that are satisfied. You tend to have data and information that is available to show your value. And you have processes that have been as lean as possible. And ultimately, you have great value and great impact and outcomes as well. So it's kind of a combination of different things kind of moving forward. Now, this community hospital, the case study here is Community Memorial Hospital. We made the name up. It's not the real hospital, like I said, that I worked with probably a dozen years ago. But it kind of cites an example and may contribute to our discussion here. So the exercise was, what types of interventions, given the circumstances that were there, and as I indicated, they're relatively extreme, but believe me, there are hospitals out in that desperate a shape. What would we recommend, and kind of where would we start, so to speak? So Nicole, do you have the outcomes or the data from the exercise that we've tabulated? Would you put it up, please?
Yep.
Great. So basically, this is really what came down. It's interesting. This is very consistent. We have 4 cohorts, and we have tabulated it both among the whole cohort and in terms of the individual cohorts as well. So this is your individual cohort in terms of the scores. The concept was, and I really tried to you can't do everything for everybody. You have a finite amount of resources. So that was the reason that we decided to give you a certain number of points, just as you have a certain amount of money, and ask where you might kind of put the initial effort and where you'd put the effort just in general with this troubled hospital. Towards the top, and there's a tie between educating, really doing some education, and which regarding health industry trends, reimbursement models, quality, health service delivery, community engagement, of the potential impact of the organization. That I think the assumption here is that doing some education, if our folks are not aware of what is happening, if they're kind of operating in the dark, whether it's the board or the leadership, et cetera, then it's obviously something we're going to have to deal with. There was a second high amount of points that went to providing CAH leadership development and management education support to improve overall CAH performance. Very high in all 3 of our cohorts, although generally not at the top of any of them, have been assisting critical access hospitals in identifying potential areas of financial and operational performance improvement. So that one came in kind of at 3rd place. Another area was providing direct technical assistance to critical access hospitals for service assessment, perhaps physician-hospital alignment or market analysis, for example. And one of the things that I can think of here that might be indicated in this relatively broad category is that physician-hospital alignment. And sometimes it has required people coming in from the outside to help hospitals and medical staff kind of deal with issues that might be keeping them apart. Then we go down quite a bit to facilitating or supporting community processes, work with communities. There's supporting kind of a community, some sort of an assessment, maybe helping critical access hospitals and multi-hospital networks. So networking becomes an area, supporting evidence-based protocol implementation, and providing kind of technical assistance. Other things that were mentioned were kind of working on the patient satisfaction side of it. We had heavy emphasis from one of our respondents about kind of talking to CEOs to learn about his or her relationship with their leadership, their challenges, their leadership vision, et cetera. And so those were the pieces that came out. One of the things that I can say is that I really think that they are kind of right on. It's clear to me that the vast majority of our state flex programs kind of understand approaches, at least from our perspective, in terms of what's going to need to be done, but have some differences in terms of perhaps the priority, et cetera. So what we're going to do now is kind of delve into some of these, and I'm going to use it kind of broadly in kind of breaking down these areas rather than going through them one at a time. So we're going to start with leadership. And one of the areas that has been brought up by a number of our folks has been that of the boards. And so I want to start talking a little bit about that. This board obviously, as I recall, had some education, and it had not had much education whatsoever, and didn't seem to be at least a part of the problem here. But I'm interested more on a larger scale. What are you folks seeing on board education, and are you sensing this to be a significant problem? So what I'd like you to do is somebody from one, hit star 2. And just basically let us know, kind of who you are and what state you're from, and then tell us about what you're seeing on the whole area of board education. And then I'm going to be asking about, is anybody doing anything about it at this particular point, or do you have any ideas about it as well? Anybody seeing board education as a real problem? Okay, I'm gonna call on somebody because I can see who's on the call. Caleb, you're always good for an opinion on this. So Caleb's from Colorado, and as you've been going around, Caleb, do you have any perspective on the board education issue? Hit star 2 to respond.
Can you hear me now, Chair?
I can, yeah. Thanks, Caleb.
Okay. So yeah, we have Jen. I've got Jen Dunn, the director of programs, here in my office with me too.
Oh, okay.
So we have seen some, I guess, evidence of, I guess, a need for further board education. We have a fair amount of, I guess, board turnover and CEO turnover. So we did a webinar series in the spring, and we had, I would say, mediocre participation in that, maybe around half a dozen to a dozen, maybe 8 to 10 people. Some boards and hospitals were well represented in that they had an entire board in the webinar, so one person registered and then their entire board was present, and that might not be captured on registration. Survey requests and things like that, we've asked for feedback as far as what is needed for board education. We talked about roles and responsibilities. We talked about the fiduciary responsibility of a board and whose role is what on a board compared to the CEO and different things. It was a 3-part webinar series that we partnered with Bill Charney from Charney and Associates to facilitate. And it was well received, and I was pretty happy with that.
Yeah, and this is Jen. I would just add that we've done board education periodically over the past few years, but as Caleb alluded to, there is a lot of turnover that we've seen in both the CEO and the board, at the board level too. So the series that we offered this year, provided a recap of some of the material that was presented in the past, but then also we worked to see if we could present some new material, some of that, as Caleb mentioned, the different roles on the board and the relationships with the CEO and the board chair as well. So.
Okay. Thanks.
That
How about anybody? Hello?
Are you there, Terry? Does that
Yes.
answer all the questions?
It does. Anybody else want to jump in on this?
I can jump in. This is Jill from Arizona.
Hi, Jill.
We contracted with iProtean, which is a web-based board training, online board training module. And we have 3 of our hospitals that use that the board training modules. And several of them will play or will, play or show the modules right before a board meeting. Others, they expect the board members to view the modules on their own time. But I think that everyone's really busy, that the most successful way that I've seen is when they show the modules before the board meetings. And I think that's really, really helped the board members. Most of these board members are community folks. They're not bankers. They're not hospital people. They're just community people, so they need a lot of training.
Yeah, I would agree with you. You know, it's interesting, too, because we picked up some really strong concern in, I also facilitated the Cohort A, and we've also been picking it up in our Mississippi Delta Performance Improvement Program in general, which is just simply things have gotten so incredibly complex, and now on top of that we have the political controversy over healthcare reform, et cetera. And the report is that I'm hearing particularly, and this would be particularly pronounced, I would say, in the more conservative states, was that there's somewhat of an expectation on the part of a lot of hospital boards that, you know, this healthcare reform is going to be short-lived, and that in essence, when, you know, the different party comes in, then it's going to simply, everything will swing back into place. We think that's just, you know, wishful thinking at its best or worst in that regard, because there's just no question about the fact the entire industry is moving in a direction that's really going to require you know, proof of value, and whatever it's going to be, it's going to be way different than what it is right now, meaning that board education becomes absolutely essential. And it'd be interesting. One of the things that we can do, if maybe, you know, if Arizona and Colorado are willing to share some of these approaches, is start to collect examples of what has been happening. And in other words, let's try to grow our flex knowledge base on board education, because it is always a challenge. There's absolutely no question about it. But the concern we see is that if a board doesn't support a hospital administrator who's, you know, hopefully moving into more community-based approaches, is trying to do things differently, it sets up the situation where the administrator may be fired, or the administrator may get just totally frustrated, et cetera, in that regard. So, yeah, on the, you know, on my upstream, downstream kind of a metaphor, to me it's the farthest upstream that we're going to have, and we're hearing feedback from the hospitals themselves now, which is relatively new for us in the Mississippi Delta, that this has become a real issue. Let's talk a little bit about, there was also a situation that is really, I think, going to be important as well, and that is the hospital and the physician relationships. And you know, as you folks probably know, primary care physicians not only in short supply, but are going to be absolutely key to the medical home, community care organizations, the accountable care organizations, et cetera. Anybody doing anything or have anything to share about how we get physician leaders or critical access hospital leaders working more closely together, or have you identified physician leaders in your community that you, or in your state that you can lean on in this regard? Any thoughts on that?
Hey, Terry, can you hear me?
I can.
So this is Caleb in Colorado. One of the quality improvement programs that we have is called iCare. It's to improve communications and reduce readmissions, and we work with the critical access hospitals and their provider-based clinics to help with transition of care issues and efforts. So when we re-engage those facilities starting in July in the next grant year, we will ask for a provider/physician champion to be in on that engagement meeting, which usually takes about an hour or two to demonstrate and support the project and the efforts to demonstrate the importance of, you know, tracking diabetic care measures or heart failure measures or whatever it is. So that's one way that we're efforting provider engagement and quality efforts.
Terrific. Anybody else? This is one of these difficult, I'm sorry.
This is Joyce from
Hi, Joyce.
Also. Hi. So one of the other things, and it's interesting from Caleb bringing up the physician connection. One of the things that's just really starting here with one of our critical access hospitals is at the border on the left, Holy Cross Hospital, right at the border of Mexico, with the fire district surrounding there on community paramedicine. And so this is, and so the doctors, like the ER, the head of the medical staff at Holy Cross, and the primary care docs are all in line to work with the community paramedics to follow the patient as they are discharged to prevent that readmission. So, so there's these other avenues that are happening, and again, the paramedic program is, you know, we're just ready to begin it, and but it's pretty exciting to see that all that's coming down and how the integration of the doctors has to be in helping the patient once they're discharged.
Yeah, that's really very interesting, and I really like the example too, because it gets back around to our EMS component, so that we're starting to integrate in a real way that whole EMS piece into your, which sounds kind of like that a quasi, you know, medical home or model, which is at the heart of the care coordination model, et cetera. So that's really very, very interesting.
And it is, especially because it's not only, we have like 8 fire districts that have come together that want to do this pilot project. So we have the urban and the rural, because, you know, sometimes our EMS in the urban are seeing these patients or whatever. So it's pretty neat. And so I really liked Caleb's example, and gets me thinking on, you know, the kinds of things that we need to monitor and really focus in on with this role of the physician and that system, like you said, Terry, how all this is going to work.
And you know, the really fascinating piece about that, and let's make a note also for our folks here to keep track of that. That really sounds like an innovative project that we're going to want to highlight. But I guess it was in March we had a population health summit meeting. This was one of the things that I found most fascinating about the couple of days that we spent with a group. And by the way, that population health report, kind of what we observed in terms of how you bring population health, what is the role of critical access hospitals and population health, et cetera. has become even more timely than before. But it's more timely now, obviously, than it was in March. But we had 2 physicians participate in that. One from the University of Virginia. We also had several flex coordinators participate, and one from the University of Virginia who had done a lot of work at the Mayo Clinic, and the other from Harvard Medical School, Dr. Schreiber and Dr. Taragonsky. And their concept is that physicians view the world so differently from hospitals that, in essence, it's going to be difficult to get them to lead these medical home models. And I know we've got some of those out there, but just by and large, we're going to have to look at strategies to use teams of folks with physicians being in an advisory capacity, but both doctors pretty adamantly said don't count on those people to lead them. They don't have the skill set, they don't have the time, so we're going to have to kind of facilitate them, bring them in when we absolutely use them. But to me, what's exciting about it is it really opens up the possibility for more health educators and, nutritionists, et cetera, that would work in that team with physicians. And so they're going to be absolutely key. Physician leadership, as much as anything else, to me, is going to be this huge challenge kind of moving forward. So it's good to see that we've got flex programs kind of being enlisted and bringing them all together. How about in terms of leadership education? What's going on the broader front of, we've talked about boards, we've talked about physicians, how to get them more involved. And one other thing I'd say about the physician leadership is that it's slow, but some of the medical schools are starting to build in these, like Harvard, which you'd expect, is starting to change its entirely medical school approach so that they can incorporate more of these community-based, team-based approaches. But what about the leadership in general? What sort of things are going on in states around the country within the flex programs? Lucretia, I'm gonna pick on you. Do you guys have anything in Ohio, or what are you seeing in Ohio? If you wouldn't mind giving us a perspective of kind of what's going on out there in the whole realm of leadership. If you hit star 2, Lucretia, you can talk.
She's just listening through her speakers on her computer, Terry. She can't speak to us.
Oh, okay. I'll move it over then, and I'll pick on somebody else here. How about Beth? What's happening in Louisiana?
Beth, if you can press star 2 on your telephone keypad.
Hi.
Hi, Beth.
Yeah, I'm getting echo.
Yep, hold on one second. I'm going to mute all the lines again. So Terry and Beth, you'll need to hit star 2 again.
Okay.
Yep.
Hold on one second.
Can you hear me now? Okay. We
can't hear Beth.
Terry?
Yes.
Okay. Beth?
Sometimes we hit star two a couple times moving in here, so maybe that's it. Beth, are you?
Hi. Okay.
There you are.
Hey, did y'all hear anything we said?
No, so you're going to have to repeat it, please. I didn't hear it.
Okay, hold on. I'm going to give it back to the phone, back to Candy.
Okay.
We were saying that we really didn't have anything on general leadership to really talk about. We were wanting to comment earlier about board training, though, because that is something that we've gotten feedback from our hospitals about that they're very interested in, and we do have one, in fact, set up for next week.
And tell us a little bit about what the program's going to be about.
It's just a very introductory course, and hold on. Oh, okay, so these are the topics listed. Is what makes a CAW different from other hospitals, balancing our not-for-profit mission with the need to be profitable, how do Medicare and Medicaid programs limit profitability or affect it, what does it take for a CAW to be successful, what are the challenges of operating a CAW in the South, and how can we support management, and then what does the future hold, which we suspect is going to be a big part of this.
Now, we had been, you guys are, Louisiana is a part of our Rural Hospital Performance Improvement Program. And
yes.
So in essence, again, are you seeing the board training as being a big need?
Oh, yes, they requested it.
Okay, so they've requested it in that regard. Okay.
Hey, this is Beth. We did a strategic planning meeting last, I think, October with the critical access hospitals, and that's the number one thing that they specifically asked us to provide.
Yeah, that's kind of.
One of
Go ahead.
One of the examples that they gave, and I think this is probably a lot of hospitals or experiences everywhere, but they were giving us specific examples about the type of thing where, you know, people have gotten very accustomed to they can go to the hospital and get care without being charged, and whether it's an emergency or not, whatever, they can just show up there. Well, now that the hospitals are trying to change that, to enforce their policies, their boards are very reluctant to let that happen because of, you know, complaints and stuff in the community. So that's one of the big things I think that they're looking at.
Okay, great. I find that really fascinating too, because other states have not really seen this as being a huge issue and need, but I find it very revealing that in Louisiana it's a number one need as such, and I'd suggest that it's a big need in virtually all states, although we've got a lot of things going on in that regard from leadership standpoint. Let's talk about leadership just a little bit more in terms of...
Carrie?
Yes?
This is Susan Triggs in Virginia. Before we move on, hi, could I just request that agenda be sent out to people? We have a meeting coming up with our Critical Access Hospital, our Virginia CAW Coalition meeting coming up, and I would like to put this on the agenda, but I need to know how to frame it. So anyone that's already done it, if you could send me information, I'd really appreciate it.
That would be terrific. Why don't, at a very minimum, Beth, if you would send your agenda to Susan, that'd be appreciated. Anybody else that would have anything to share with Susan? By the way, Susan was one of our participants in our Population Health Summit meeting.
Are y'all interested in the contractor we're using also, or just the agenda?
Yes, I would be interested.
Yes, I would be too.
Great.
Okay.
What other sorts of things? Now let's talk about hospital administrators. We know that they turn over every 3 to 4 years. What kind of things are going on from a leadership support program, kind of in your states? I've got a number of things that have been kind of suggested or brought up, and I'm just wondering, is there anything that's going on besides what we've already talked about that you'd want to share with us?
This is Joyce. One of the things that we really have going on, and it's really statewide as far as leadership of staff, is, and this is one example, is with level 4 and level 3 trauma coordinators on how they're to manage their section. Is that what you mean?
No, I'm just talking about leadership in general. Yeah, that's an example of maybe EMS leadership in that regard. So
well, it's ED, through the hospital, and
yeah.
So it's educating how, and what's so neat, we have a meeting coming up mid-July. It's statewide with the Bureau of EMS, and in fact, so far we have 2 critical access hospitals who are bringing their quality manager, their trauma coordinator, and then sort of the senior person over those 2 people, and coming as a team to know how to structure and lead, this component of their hospital. So, some of these tools are, no matter what you do, leadership is leadership. I don't care what position you have in an organization. So, I view it that way anyway.
Yeah, I would agree with you, Joyce. And a number of years ago, I saw a presentation that really struck me, and that was called "Leading from the Middle." And I just found it really profound in the sense that one of the things that we pick up in the Mississippi Delta as we're working closely with hospitals down there is the lack of training and support for department managers as well. And all too often they may be left out of some of the leadership strategy that's developed. And what we found, and I think what the hospital leaders are realizing, is that unless they see themselves as leaders, they may be managers, which may be their primary responsibility, but they become a vital part of that leadership team. And then, as I think you're saying, there's also the informal leaders, the guy, the maintenance guy who just carries a lot of weight in the facility themselves as well. So I just totally agree with you, from the CEO to the board to the physicians all the way down. I think we need to be mindful of that. And if you really want to make significant change, support programs for all those folks become extremely important. Although the farthest upstream, as we talked about before, were the boards and the hospital administrators, et cetera, but the same thing applies with EMS.
Well, right. You set the culture, right? You set the culture.
Absolutely. Which really takes time to do. So you guys realize that in that regard. Is the leadership, in order to set that culture, it's a significant mistake, we think, that hospitals made in putting in electronic health records and in general, is that because of the urgency and because they were moving, it took a while. I mean, the why are we doing this really wasn't explained very well. And I think the same thing applies to why are we suddenly doing population health? Why do we have to, why do we have teams now where we didn't have it before? So those pieces, I think, also kind of reflect some of the responses on the exercise with, that educational piece and laying that foundation is extremely important. Something that came up.
I have a question.
Sure.
This is Jill. Did I interrupt you? It sounded like you were done.
No.
Oh.
You guys, I want you guys to talk. Go ahead.
I'm wondering, and this is something I wanted to always do, is have an orientation packet for new leaders, new CEOs, new CFOs, new CNOs that come into the position. And I don't know if there's something already out there to expand upon, or or do you know of anything that out there that there is, or have recommendations of everything that should go into an orientation packet?
Now, who is this again? Because I didn't.
Jill Bullock in Arizona.
Oh, Jill.
Real quick, this is Susan. We're having a fire drill. I have to leave. I'll be back.
Oh, dear.
Susan.
Understandable.
I thought maybe Susan was going to tell us that she's got the stuff all together and would send it to you. But anybody else have anything like that that you might be using out with your hospitals? Well, Nicole, why don't we make a point of trying to find something like that? And if it's not, I think that's a great idea. Absolutely. And I think the same thing for board members. I mean, why not, if we've got, I know some of you are doing a great job of trying to put programs together in that regard. Maybe there are even packets for critical access hospital board members that could be shared as well. So it strikes me as a means of providing additional support here, and also gives you something as a flex coordinator to reach out to the new hospital leader, new administrator. You've got something to share with them.
Hey Terry, this is Caleb from Colorado.
Mm-hmm.
So we don't have a packet. It's something that we've thought about developing, but we have a webinar series that we have one of our financial gurus do with us quarterly. And on our next webinar series, we're going to talk about some of the significant concepts and or current operational management of critical access hospitals and future issues to watch. So, if you're new to critical access hospitals, it's important for you to know about cost reporting and primary care strategies and strategic planning and flexibility and population health and operating efficiency and best practices and impacts of Medicaid expansion, and then some of the data that we do. So we're working on a webinar right now on that topic. We don't have a packet though.
Are you going to, kind of record that so it would be available to your hospitals, if somebody, that a new board member, I'm just wondering how you're planning on using it, Caleb.
Yeah, so we record all of our webinars and post them to either the Critical Access Hospital website, which all of our members and critical access hospitals have access to. So if you miss that as the CEO, but you want to catch up on it, you have access to that 24/7. And then we also we have the opportunity to make that available to other states and other agencies. A lot of our swing bed webinars and resources, we are able to partner with other state offices and make those available as well. Usually the live webinars are what do best, but yeah, we do record them and make them available after the fact.
Terrific. That's terrific. And we'll start, as I indicated, I think this is a acute enough need, and we've heard it now in our various cohorts. We'll start collecting these resources, just to link into your page, for example, and start to put some of these resources together here at TASC. But appreciate that. And the reason I think we're talking, and TASC was created originally, one of the reasons is so that a lot of great things are going on, and we just got to be, we've got ourselves to help you all get this into some sort of a common format so that you can access these materials. Rather than Susan, who's a relatively new flex coordinator, having to do this all herself, she can kind of tap into the good work that's already been done. The other thoughts that came up, and I'm going to go into finance a bit here in the remainder of our hour, we're using of mentors. In this example in this hospital, one of the people in the cohort, I think it was yesterday, had suggested, well, why don't we get a mentor for this brand new administrator? Again, one of my favorite quotes is that hospitals, from Peter Drucker, are the most complex organizations in the history of mankind. And in essence, to be a young CEO out there, totally in over their head in that regard, having mentoring is of real value. And for example, Kathy Johnson, the woman who presented in the webinar that I did, I think it was last week, after she retires, that's what she wants to do. She wants to go around helping to mentor other hospital administrators. So maybe there's a means of identifying mentors that, in a case where a hospital leader, a new one, or somebody who is out there that really needed some help, there would be either a retired administrator or somebody who would be willing to help from a mentoring standpoint. A second piece has to do with cohorts, and I think that ties into maybe gaining access to networks, which were another thing that were suggested here, is that leadership cohorts, kind of getting these people together periodically, was another method that I know has been used very effectively. I know Nebraska's done tons of cohorts, and we have one network in Wisconsin, for example, that this just blows me away, has 31 cohorts or round tables, 31 different types of healthcare providers, lab managers. I mean, amazing. It's the Wisconsin Rural Co-op. But they see great value in the chief financial officers networking together, the directors of nurses networking together, and the CEOs networking together. And I find the same thing with physicians. Get medical leaders kind of working with each other, because in many cases, these folks are, particularly the physicians, seem to be as isolated as anybody else. Anything else or any other suggestions on on things we might do on the leadership side? Let's talk a little bit on the financial side of it then. Many of you gave kind of heavy weight to, in particular, let's get back to this model that our Community Memorial Hospital model. Anybody want to state an opinion on why the financial and operational performance improvement would be a priority here for this hospital? Or what finance has to do with the leadership side of it?
Well, they were losing 60% of their patients to outmigration, and that's, I don't, geez, that's a lot of their money going away.
Yeah, and it's a community problem too. It really gets down into that, and this is one of those areas that just, I think that this is the most unrecognized potential for any critical access hospital out there. I firmly believe it. There's also money in better revenue cycle management, et cetera. But when you're losing between 50 and 60, and I believe it was the state of Tennessee that did a study that showed that on average, over 50% of the market for the local rural hospitals left. So the 60% figure is not an exaggeration for many hospitals. That's just the average hospital. I believe it was in Tennessee. Then in essence, community work has the potential of reaching those people who are leaving and providing feedback into how we capture more of that market. There aren't a whole lot of, we can be more efficient, we can get more money out of a revenue cycle, but the community piece is extremely important as well.
Well, and you talked about they're not using swing beds, which, if your costs are 90% fixed and you have an empty bed, you're not getting anything reimbursed for that fixed cost. But if you put me in that bed, you're at least getting, something back. So that's huge dollars just being wasted right there. And then the high ratio of inpatient to outpatient days, you have a much better margin on outpatient services than you do inpatient. So that's a big contributor to your negative 4.5 operating margin. No charge master update. All of these things are issues that you need to talk to the CFO about.
Right. two of the pieces that I think have been really important here were the revenue cycle management is assuming greater importance all the time because of the expansion of the insurance. In essence, the new insurance people who are coming in through the insurance exchanges are generally going to the bronze level, meaning you might have heard this already, but the revenue cycle, in other words, they've got huge co-payments, maybe 40, significant co-payments in that regard, meaning the hospitals need to capture that revenue, and that co-payment is huge as well. And I think you hit on the swing bed issue, the keeping people locally. One of the things that has been brought up by other folks as well, and I totally believe it, is that when you have a hospital that's in this bad a shape financially, it's really difficult to get them to think of anything other than the bottom line. It's kind of Maslow's hierarchy, and my experience, and I think several other flex programs brought it up, is if they are bleeding financially, trying to get them to improve their quality or even to focus on things that have more of a long-range impact has become really difficult. So the financial piece, I think, very often has to be done kind of in association with some of this leadership work at the same time. And perhaps, as some suggested, several of the comments here, you might want to do an initial assessment right at the very beginning to find out what are the you've got some data, you've got some information, but maybe doing an assessment of leadership, et cetera, would be the way to go. And I know in Arkansas, for example, they've developed some programs to do that initial assessment, to look at the finances, to look at the leadership, to just do it almost like a 360 assessment to help, kind of diagnose and treat the problem. Obviously, that's going to take, quite a bit of resources, but in essence, they've made that, I know in Arkansas, they've made that technical assistance available to the hospitals that are struggling the most.
Yeah, we have something similar to that with the that financial guru guy. So we have the opportunity to get on a financial one-on-one call where we'll look at the financial, the flex monitoring team reports and iVantage data, and if you want to send over your cost report, we'll take a look at that, and then we'll get on the call with you for an hour or two and just go over it with you. Make sure we have any suggestions or questions and things like that. It's not as widely accepted as I expected it to be, though. My phone is not ringing off the hook for those calls to happen.
And we've got just a couple of minutes left. That is the thing that we found that has been frustrating. Missouri has offered support, Arkansas has support. In many cases, the hospitals that need it the most are the most reluctant to accept help, and there's a variety of reasons, that we could. Part of it is that those that are struggling the most are those that have most resisted help from the outside, flex program or otherwise. But I know Melissa in Missouri was kind of lamenting the fact that the hospitals that she would like to help, the ones struggling the most, have been kind of reluctant to trust. And in this particular case, she's out of the health department in Missouri, but it's been an issue. Again, I don't want to keep you later than that. Not everybody has spoken, and in the course of the discussion, I'm going to make sure that at least everybody has. So if I didn't call on you today, or you didn't speak up today, then in one of the other sessions, I'm going to, just make sure that every state is heard from. Again, with the number of states on the call, I don't want to call on everybody that might not have spoken at this particular point, but we do want to know what's going on in some of the other states that are participating here as well. I think we're gonna end with that. I really appreciate the suggestions, the conversation. In general, we've learned a lot, and hopefully you have as well. One of the things that I got out of this is that we are, task needs to help the states, kind of particularly in this area of leadership, kind of gather resources, make them available, and we heard particularly on the board side of it, there was a real interest in doing that. Now this is just one cohort, but I think collectively the suggestions we're getting from the 4 cohorts themselves we're going to kind of put together, and there will be one final kind of a report that's going to go out with these suggestions and ideas in it as well, and it's really been very helpful for us to get your suggestions. On your screen is the next plenary session, which is going to be on workforce. It's next Wednesday at 2 o'clock. And then there are other plenary sessions to follow. And we'll get back together. I think we have three or four meetings. I think there's 3 meetings scheduled with the cohort.